Hello, everybody. Thanks for joining us on another JACC Author Interview. My name is Mitsuaki Sawano, Executive Associate Editor at JACC, and we are honored to be joined by Dr. Karen Joynt Maddox from Washington University School of Medicine, St. Louis. And today we will have Karen kind of explain about the research original article that has been published at JACC. The title of the article is Hospitalizations and Mortality Among Medicare Beneficiaries at Cardiovascular Risk, Disruptions and Recovery from the COVID-19 Pandemic. And with that, I would like to have Karen describe the article. Thank you for joining us, Karen.
First, thank you so much for having me. It's an honor to get to chat with you about this. And I also want to go ahead and thank all of my co-authors, particularly Rishi Wadera and RJ Waken, who really played a huge role in bringing this forward. So to thank all the co-authors as well for making this happen. This is a labor of love to get it all to the finish line. So I'm thrilled to get to talk about it a little bit today. So our main question for this paper was trying to understand what happened sort of not in the peak moments of the pandemic, but really in sort of the couple of years that followed, so 2021 and 2022, as business kind of got back to normal, but we knew that there were still these lingering effects of the pandemic, particularly on beneficiaries with cardiovascular risk factors or disease. So big picture, the goal was essentially to do an epidemiologic look at the Medicare population and understand among folks with cardiovascular risk factors or cardiovascular disease, what happened in those couple of years after the peak pandemic in terms of utilization and patient outcomes.
Thank you. I mean, it's important to understand what happened in the later phase of the pandemic. We kind of know what occurred during the first year of the pandemic or the two years into the pandemic, but we don't really have too many reports on the later phase. So can you talk about the key findings and key takeaways from this paper?
Sure. So we had about 50 million folks in both the pre-pandemic, so 2018-19, and sort of the late pandemic, the 2021-22 timeframe. So the totality of Medicare beneficiaries, fee-for-service and Medicare Advantage. And from the pre-pandemic to late pandemic, the populations were relatively similar, except for a big shift toward Medicare Advantage. But what we found was that utilization and outcomes were actually quite a bit different in that 2-year period, again, post that sort of the peak 2020. So hospital visits were 8 or 9% lower overall. So if you look at the hospital curve, we're sort of going along at a certain utilization, huge drop in COVID, which we've seen documented before, and then a recovery, but not back up to the same level as before in terms of hospital utilization. We saw outpatient visits actually recover back above, and part of that was driven by telehealth, right? So we had this new sort of modality for people to access care. So you see outpatient visits bumping along, drop, and then go up and up above their baseline not post-COVID, post-peak COVID. But I think the most concerning thing was we saw also a pretty sustained increase in mortality. So similarly, mortality on a certain trend, big spike during COVID, and then continued spikes along with COVID waves, such that the overall mortality among Medicare beneficiaries with cardiovascular risk factors or disease in that period was about 20% higher in sort of a relative scale, depending a little bit on which group you're looking at. So real differences in both utilization and outcomes in that sort of near post-pandemic, late pandemic, whatever we're going to call that period in that time.
Thank you, Karen. And you spoke about certain populations about holding much more vulnerability towards mortality, hospitalizations. What did you find from these subgroups that you looked into from the Medicare data set?
So for the hospital visit rates, we found that the decreases were greatest in rural and socially vulnerable areas based on social vulnerability index, a little bit less so in Medicare Advantage. For the outpatient visits, we saw that it increased most in the urban areas. It was pretty similar by social vulnerability and up most among Medicare Advantage. But then to focus on the mortality again, we really saw that the biggest increase in mortality was among socially vulnerable individuals or people living in socially vulnerable areas, and among Medicare Advantage compared to fee-for-service beneficiaries. We did not find a big difference in terms of the mortality increase for rural versus urban. So we looked at that as well, but really for mortality, the social vulnerability and Medicare Advantage were two of the big differences.
Thank you, Karen. So I think the listeners are wondering, why we see this trend. And, we can't really exactly tell why. We don't see the reasons behind the Medicare data itself. We do have to, in some aspects, speculate. But what do you think really happened over the discussion over the pandemic or the late phase of the pandemic?
Yeah, and you can imagine we had the same question when we saw the numbers. What on earth is happening here, and why do we see it so consistently and persistently? I think there's I've sort of bucketed it in my head, at least, into sort of three different areas. And I think each one is probably contributing. I think one that we have only circumstantial evidence for, but this is why lots of different types of researchers exist, is the biological. There's also perhaps a behavioral, and then there's potentially a systems bucket. So to sort of go in order, biologically, we know that COVID was quite dangerous, right? COVID itself was quite dangerous, and the aftermath of COVID was quite dangerous. There's a study that came out in Nature Communications quite recently looking at Swedish populations and showing that the increased risk of death, all-cause mortality or cardiovascular death, was higher more than a year out in anyone who had previously had COVID. So there's a huge tail of COVID itself that we don't totally understand, presumably something related to inflammation. Every winter, I just rounded for 3 weeks and we saw flu and COVID and para, meta, pneumo, whatever virus is out there, right? Really triggering heart failure, ischemic stroke, and acute MI. So there's got to be something biological to sort of how the virus drove things, either acute viruses or this sort of tail of the effect. Not my scientific area. I know people are working on this. So I will just say that I think there's something to that. Though again, as you said, we don't know exactly. The behavioral piece I think is important too. We know there was care avoidance during COVID, and that seemed to persist, particularly among women, among people from some racial and ethnic minority groups that may have suffered from worse access in the first place. We don't know whether that translates into this data set because we can't ask people those questions. But I think there's always a lingering concern that some of the behaviors around care seeking may be a little bit different. Access to care may be a little bit different with backlogs for procedures, prevention, things like that. And then the systems pieces of, were hospitals strained? Is there something different about care delivery or about the healthcare system? It's hard to know. There's another paper that just came out on JAMA Internal Medicine about skilled nursing facility supply, showing that it was quite decreased. So if you have staffing problems in skilled nursing facilities and people are, staying in the hospital too long, what does that do for functional status, for mortality? There were just so many things changing at once. I don't think we can say that there's any one sort of, element that was driving the rest, but I do think it's worth understanding in each of those three buckets what happened to the degree we can. This is not the last time that we're going to face some sort of a challenge to the healthcare system. And so I think understanding what might underlie those is really important.
Thank you, Karen. I totally agree. Looking at these patterns or temporal trends across the pandemic, it's really not about, just what happened. It's also about preparing for the next emergency. I hope it doesn't happen, but sometime it may happen. And so understanding where our healthcare system is really vulnerable and where it falls short, how we can strengthen those weak points, probably is going to be the takeaway. And we have to be prepared for that. And I think that's what it really truly illustrates in your article. And I really encourage our listeners to go take the beautiful figures and, of course, the article itself. It's full of the content over the last the 4 or 5 years, and it's really to understand where we fall short in cardiovascular health and who's going to be the most vulnerable population in the US. Well, thank you for joining us, Karen. And thank you all listeners for listening. Until next time, take care.
Thank you.